Hello, everyone. My name is Meena Ramchandani. I'm an infectious disease physician at the University of Washington in Seattle. This podcast is dedicated to an STI review for healthcare professionals who are interested in remaining up to date on the diagnosis, management, and prevention of STIs. We welcome back Dr. Helen Stankiewicz-Carita to discuss HPV-related diseases in the anal canal. Dr. Stankiewicz-Carita is an infectious disease physician and an associate professor at the University of California, San Francisco. Welcome back, Helen.
Thank you, Meena, for having me back.
So let's discuss a big topic in sexual health, and that's anogenital warts. And let's touch on some areas that can be challenging for providers when seeing patients with anogenital warts. So why do patients get anogenital warts? Are they associated with acquisition of anogenital HPV infection?
This is a great question. And anogenital warts are caused by certain type of human papillomavirus, most commonly HPV 6 and 11. And they are considered low-risk HPV types because they don't cause cancer. But they cause visible warts over the skin or mucosal surfaces of the anal genital area. So the answer is yes. The development of anal genital warts is directly associated with the acquisition of anal genital HPV infection.
Now, how do anogenital warts present? How would a provider distinguish them between anogenital warts caused by HPV and wart-like lesions, for example, from other genital infections, for example, for syphilis?
Great questions. So the anal genital warts, I would say they are usually fairly easy to recognize on exam, and they have this typical appearance of like cauliflower or plague-like appearance, but sometimes they can be just a little bit raised or elevated or tend to be flat rather than that typical pedunculated lesion. Most of the times, patients will not have any pain. They will be painless. And when you palpate them, they should be soft to the touch. Now, there are other infections like syphilis, for example, secondary syphilis infection that can cause a condyloma lata. They tend to be, or they can look exactly like HPV warts, but they usually are bigger in extension and moist. When you look on exam, they are, instead of like being that dry-ish warts from HPV, they tend to be more moist. Or the patient will also tell you that there could be systemic symptoms as well. So in those cases, you need to get serologies for syphilis, for example. Another condition that I saw one case is herpes can also mimic genital warts, and they can look exactly like an HPV wart, but it's described that most of these lesions are painful, and also they have a kind of like crusting or exudate on the top. But with our experience, I think we both know that herpetic lesions are not always painful. So when there is a diagnostic uncertainty, I always recommend biopsy. And I want to emphasize that to the primary care providers who may be seeing these patients. A relatively simple step that you can do to clarify the diagnosis and prevent an inappropriate treatment or delayed a targeted treatment.
Who would do the biopsy? How is that done? I haven't done a biopsy before, especially of the anogenital area.
I say relatively easy because we do it in our clinic all the time. But for primary care providers at the different sexual health clinic, sometimes you will use like a punch biopsy. You can do a punch biopsy that's relatively straightforward and easy. You don't need to suture the lesion. You can do a 3 millimeter or something like that. It's tiny, it's small. You don't need a super big biopsy. But if you cannot do it, which is probably the majority of the audience, refer them to either dermatology will do these biopsies fairly easily, especially if they are in the external genital areas or skin. And if there is something more deeper in the anal canal, for example, colorectal or general surgery can see these patients. Or if you have in your clinic a high resolution endoscopy provider, that will be the ideal person to evaluate for anal canal lesions. The OB can look into the cervix or vaginal areas if there are lesions in that anatomical site.
I guess one could also swab the area if you're thinking about herpes on your diagnosis and sending for an HSV PCR. And then if one had access to a dark field microscope, they could also put a slide on those mucousy lesions and look for treponemes. Do you find that persons who have anogenital warts from HPV tend to have those warts for a longer period of time than someone, for example, for syphilis or herpes, or is there a variety?
I will think that probably the timeline will be different and more slow and maybe slash chronic for the HPV. There are some studies, some of them done at the University of Washington back in the days, that after the exposure to the HPV 1611, there is incubation per se. We can call it incubation period of like a couple of weeks to a few months before the lesions will appear, the warts. And the warts just tend to be present for at least a couple of months before they disappear. So about 3 to 4 months. And again, a lot of the time, because they don't cause any other symptoms, patients may not seek care or evaluation immediately. So I will think that the HPV wart-like lesions will probably be there for longer than herpes or syphilis, for example.
Let's say you have a patient who presents with some anal lesions that he said has been there for several years. He's not concerned as he has a history of anal warts. And so you do an anoscopy to evaluate the lesions a bit better. What features would you be concerned about for anal dysplasia or precancerous lesions?
This is a great question. And it's something that I really encourage providers to keep in mind when you are seeing or evaluating patients with warts. So when I examine warts, the features that are concerning for dysplasia, or most importantly, cancer, can be bleeding, ulceration, having this atypical or unusual pigmentation, like grayish or darker pigmentation, for example. If I'm seeing them in my clinic with a high resolution endoscopy exam, I will look for atypical blood vessels. We can see that on the exam as well. And those can be highly concerning, particularly for cancer. If those features are present, I strongly recommend a biopsy. And if you cannot do those biopsies in your clinic, I will refer them to a high resolution endoscopy clinic or colorectal general surgery for an evaluation. Now, the high-grade lesions or precancerous lesions, they usually don't look like warts. And they are flat and they can be very subtle. So that's why when we look with a high resolution endoscopy, we really have to pay a very close attention because they sometimes can be really hard to see or distinguish from the regular mucosa. And that's why we use the vinegar or acetic acid and use the Lugol's iodine to kind of like help us differentiate those lesions and look these lesions with light and magnification. So that's kind of like what we do with a high resolution endoscopy. I tell my patients that ask me sometimes, like, I just had a colonoscopy, why they didn't see this? And I say, unless these lesions are bumpy like warts, they won't be noticeable on a regular exam when we're doing the clinic or even during a colonoscopy exam. So in patients with a prior history of anal warts, or if there's a new or persistent wart, I really want to perform the high resolution endoscopy, not only to evaluate for a recurrent or the current warts, but most importantly, to rule out precancerous lesions. And again, the warts itself are not a direct precursor of cancer, but they are thought to be more markers of a risk, meaning the presence of a wart signals a higher likelihood of developing these precancerous lesions somewhere else in the anal canal. The main concept is that there could be co-infection with different genotypes, and a person can have benign HPV types as represented by warts, but also oncogenic types, and they can develop high-grade lesions. And I think that's why the International Anal Society guidelines specifically address in their anal cancer screening considerations that patients who have a history of anal warts should be screened for anal cancer, just again, because that can be the signal for higher risk of anal cancer development.
Let's say for this patient scenario we just discussed, there are no concerning features of his anal warts. Nothing's bleeding, nothing looks bigger, no new lesions. It's pretty much the same. What are some of the ways to treat anogenital warts from HPV that a provider could do in the office? And if there were no concerning features of his anal warts, would one need to do a high-resolution anoscopy, especially if not all centers have that available to them?
So if no cancer concerns and we're just dealing with benign anogenital warts, there are several treatment options that can be done right in the office. And the choice really depends on the number and size of the lesions, where they are located, the patient preference, and also what we have in our clinic or things that we are comfortable to offer, right? So one common option is the cryotherapy or freezing the warts. And that just mainly involves applying liquid nitrogen to freeze these warts and causes tissue damage by ice, the formation of ice crystals, and that leads to cell death. So that's, I will say, can be done easily and is fairly cheap to do it in the office for single or multiple warts that are in the perianal area. I would say here in the US, we typically don't use that for the anal canal, although I know that some European colleagues are using that in the anal canal. I usually apply 3 freezing cycles in a visit and then ask them to come back in 1 or 2 weeks and tell them that they may need several cycles to get rid of the warts. Most patients do fine. They may have a little bit of burning after the freezing, but usually no major side effects. And the successful rate is about 45 to 75%. So I will say it could work pretty nicely. We also can offer an application of a topical acid. It's called a 3-chloroacetic acid or TCA. And this is something that we can just use a tiny little bit with a Q-tip and directly apply to the warts. Usually I will use this when there is just one or very few warts and when they are fairly small. So I know that it doesn't work for larger lesions because it doesn't really penetrate like the bigger, thicken of the skin. And I will do this like again once a week for a couple of weeks until the lesion is completely gone. Most patients, again, will tolerate this burning without any issues, but sometimes can cause that burning sensation for a couple of hours after the application. In our clinic, we will use more commonly the hyfurcation or electrocautery ablation of this lesion. This is something that we can do fairly quickly. It's an outpatient procedure without general anesthesia. We usually just inject a little bit of the lidocaine at the side of the lesion and then burn off that spot or the warts. We can use this in the anal canal in the perianal area. And most patients will tolerate the exam or the treatment and the post-treatment recovery just fine, although it can cause a little bit of a bleeding and discomfort because it basically cause or create a tiny open wound at the site of the treatment. And for those who have more larger warts or numerous warts, sometimes it's hard to ablate them in the office, and mainly because we have to numb it up, this lesion individually, and that can be a lot for the patient. So colorectal surgery or general surgery can take care of them in the operating room. Those are the most common, I would say, treatment options that we offer. Regardless of the method that we use or offer, I always tell them upfront that the recurrence is very common. And so one treatment is not in one and done. And again, these lesions can come back and we see these, even patients undergoing for a surgical excision. And I see them again in our clinic and just after a couple of months, the lesions can be all back again. So follow-up is important. Education is key for discussing the treatment options.
So, if a provider were to do an endoscopy for a patient and sees internal anal warts, how would you recommend treating these? Are these the same types of methods you just described for external anogenital warts?
So when I find internal anal warts during the exam, I usually explain that these are benign lesions, so they don't turn into cancer, and we don't necessarily need to treat them unless they are either causing some symptoms for patients, because remember, they can be highly vascularized and sometimes can cause a little bit of benign bleeding, I would say, or can be prolapsing to the perianal area. Some patients who have receptive anal sex, they can also express concerns about that. So aesthetic and things like that. But if they don't have any symptoms and they don't want to receive any treatment, we can watch them and monitor. Now, if the patient want to get rid of them, we have a few options, as we just discussed. More commonly, and I think in my experience, more effectively will be the hyfurcation in the office. So ablating those spots and remove these lesions. And again, if they are circumferential or larger that we cannot treat them in the office, we may send them to the colorectal general surgery for a treatment in the operating room. In some patients, we can also use a topical cream to decrease those bulky lesions and then aim to ablate or hyfurcate whatever is left over after the topical treatment. Some of them, just to mention, for example, the imiquimod or 5-FU or FUDEX is the name. These are not HPV directed therapy. So these creams are not antivirals, and we don't have any antiviral treatment or cream like for HPV. These creams will just cause an inflammation in the anal mucosa and really allow for the immune system to get rid of the lesions. And that's how they work, particularly in patients who do not have a strong immune system, like patients living with HIV or transplant patients. This approach may not work. But again, it's an option that we can use it to shrink them down, and then with the hyfurcation, just get rid of whatever is left after the topical treatment.
Yeah, that's helpful. I've found that the imiquimod cream does really help for patients, including my patients with HIV. But I guess it depends on the burden of how many warts they have and the length of time potentially.
Right. And it's hard to predict. And some patients are willing to try and do a trial. And for the audience, the imiquimod or the 5-FU are intend to be applied for 16 weeks. So one of the main concerns that I hear sometimes is like those who are sexually active or having receptive anal sex. The cream application can cause irritation and burning. So doing this therapy for 16 weeks can be sometimes, not realistic for some of the patients. So what I do, because we don't have a way to know who will or not respond after starting the treatment, I bring them back in about 2 months or so to see if there's any response. And if I don't see any response, I just move on to the next step or offer something else instead of continue the treatment when I may predict that won't have any effect on the wart.
What is the natural history of a person with anogenital warts? For example, does natural or spontaneous clearance of anal HPV occur?
That's a great question. After exposure to HPV, the typical incubation period before the clinical development of wart, it's about 3 weeks to a few months. And once the warts develop, they may increase in size and number, because once you have an established lesion, that skin or infected lesion can shed new viruses or viral particles to the healthy skin. So not infrequently, you may see one wart, and then in a couple of weeks, you may see a bunch of new satellites warts around that initial lesion. And there are studies saying that about 30% of these warts will resolve spontaneously within the 3 or 4 months after development. that's visible warts, right? What we're seeing. And I think that doesn't mean that the HPV infection is completely gone. And in fact, we used to think that our immune system will get completely rid of them in a year or two after the initial acquisition. But I think we now, as a field, we think that this HPV infection can persist in this latent state and hide in that basal layer of the skin. We may not see necessarily clinically, or we may not pick up with a swab or when we test for the DNA. That clears up the visible wart doesn't mean that the HPV is completely gone. I think that's something that the providers should be aware of in the patients as well. I always give this example with my transplant patients that they may not have, or they may have a history of warts back in the days, and then nothing for many, many years. And then they receive an organ transplant. And after a couple of years of immunosuppression, they may start dealing with anogenital warts. And they tell me, I didn't have any new exposure. I'm not even sexually active. How is it possible to have new warts if I'm not sexually active? So the truth is, the viral particles were probably dormant there all the time. And whenever our immune system is not controlling them, they may show up later in life or after our immune system is being hit, for example, with immunosuppression or with an HIV infection.
That's really interesting. That's a change in our understanding or what I've been taught about HPV warts historically.
It's very similar to HSV, actually. To me, I think more as a chronic infection. And again, we can have these kind of like latent type of state, and later on they can just replicate and create these lesions. As a field, you made about this type of thinking in terms of like the natural history, but I think back in the days, the thought was once we get it, we get rid of them and then it's gone. I don't think they behave quite like that. But again, it's an area of ongoing research. And as you know, Meena, you have done a lot of work on this, on HPV, natural history with HSV and other pathogens. It's hard to study, particularly viral infections. But yeah, the field is still learning and understanding about the natural history, particularly in the anal canal.
It speaks even more of how important the HPV vaccine is.
Absolutely. You're absolutely right. Yes. And all the efforts for those who are able to provide the vaccination as soon as it can be offered 9 to 12 years old, it's really, really important to get those shots to all the arms that qualify and before people get exposed to the virus.
So along those lines, can anal warts turn into anal dysplasia or precancerous lesions in the future? And how would you recommend a provider or patient follow their anogenital warts?
So that kind of like goes along with what we were just discussing in like the natural history. So I think now we recognize at the genital warts as a separate type of HPV infection caused by these benign types. And again, they are a morphologically distinct lesions compared to the high-grade lesions or precancerous lesions. In the past, we used to think them as a continuum, kind of like or like a spectrum of disease. That the low grade will progress to the high grade. I think you will still see and hear from some groups that that's still the case. But in our practice, in particular, we think about the low grade lesions or warts as just benign lesions that do not turn into a cancer. And separately, the high grade lesions or precancerous lesions are definitely the precursors to cancer and the ones that we want to monitor or watch over time. So for the provider in the clinic, having those warts, now or having a history of genital warts are not necessarily a concern that those lesions will develop into a cancer. But again, just consider as a marker of increased risk rather than direct precursor to anal cancer. And again, that's where that international guidelines, anal neoplasia society guidelines have in the recommendations that having the history of genital warts will put you at slightly higher risk than the general populations for anal cancer in the consideration of starting the anal cancer screening when they turn 45 years old. That is not a very solid, I will say, recommendation, but as a provider, you should have a discussion with your patient about having the anal cancer screening in those patients with prior or current anal genital warts.
So that gets me to my next question, and this was actually asked by a provider. In a patient with anogenital warts, would you do HPV testing of the warts to find out what serotype of HPV is causing those anogenital warts? For example, like would you do an extragenital swab for HPV similar to what we do for gonorrhea or chlamydia?
That's a great question. So for genital warts itself, we don't typically perform any HPV swab or testing themselves. They are usually a clinical diagnosis. So, and again, in a few cases, you may require the biopsy, but swabbing those lesions will not help with the diagnosis. If you really want a histopathological diagnosis, you really have to biopsy the lesion. So swabbing the lesion won't be helpful. Now, if you think about the anal cancer screening, if you're thinking, okay, this patient has genital warts, is 45 and older, and it meets the criteria for the consideration of anal cancer screening, in those patients, you could do the HPV swabbing of the anal canal, but for anal cancer screening, not for the wart diagnosis. So I just want to make sure that's clear and separate. And that's why now that we have these guidelines, when I see these patients, that again, we have a ton of patients be referred for anal genital warts or anal warts. And I usually separate these two components when I provide my guidance or recommendations. One is the HPV itself. The other is the anal cancer potential or risk and how we deal with that and how we monitor or screen for that.
Tell us a little bit more about the guidelines, just briefly, if you could communicate that for our audience.
Basically, we aim with the guidelines is really try to emphasize the anal cancer prevention because this is a highly preventable cancer by finding these precancerous lesions and treating them before they progress into a cancer. And what the society is putting together, the different group of people that are at the highest risk of anal cancer. So fortunately, anal cancer is relatively rare in the general population, so we can really center on those smaller groups that will benefit the most for anal cancer screening, like patients living with HIV, patients who have HPV lesions at other genital sites, for example, the vulva or the cervix, and patients who are immunocompromised, for example, solid organ transplant recipients. So now the first component is like defining those different groups that are at higher risk. And the second component is what tools we can use to do the screening. And that will highly depend on what you have available in your clinic. So the anal pap or anal cytology is the most commonly available, I will say, widely available tool. So that's what people will usually use. As we were discussing, we can do that same swab to test for the HPV DNA and just to make sure for the audience what the type of HPV genotype that we will look in that test are these oncogenic types. So actually, most of the tests that are available will not test for the HPV 6 or 11, which are the ones related to the genital warts. So those two are the two main tests that we can use for screening. And then depending on, again, your access to high resolution endoscopy, if any abnormal cytology or HPV DNA testing will be referred to high resolution endoscopy, which is really the gold standard for diagnosing high grade lesions.
How would you counsel your patients about transmission of HPV, especially when they have anogenital warts?
This is a very common question when I see patients and always patients being worried about their partners, right? But the truth is, this is a very common virus, right? We think that we all get exposed at least once in our lifetimes. But it's important to emphasize that patients that have clinical lesions or warts, those tend to be the lesions that have the highest viral particles that can be passed or transmitted to the partner. But in reality, I always tell them if there are no lesions, there could be some HPV reactivation or detection in the genital area, but it shouldn't prevent you from having your normal sexual life or having your partner. More likely, the partner is also infected with one or more types. And also, most importantly, it's impossible to know who was the original person who transmitted the virus to the partner.
Do you recommend condoms to prevent or decrease transmission of HPV?
Condoms can be helpful, especially if there are visible lesions, but because we don't have a full protection of all the genital mucosa, the effectiveness is not 100%. They help decrease, but not protect 100%.
What are some key messages you tell your patients about HPV? For example, what questions do they ask, or what things do you want them to know?
I always tell my patients that almost every sexually active patient will be infected with at least one or multiple HPV times in their lifetime. So extremely common and most commonly asymptomatic, but HPV can definitely have a broad range of outcomes, right? So from nothing or no symptoms to symptoms like genital warts or precancerous lesions, or in rare cases, invasive cancer, including in the cervix, vaginal area, anal canal, the mouth. That said, it's important to reassure the patients that having this HPV infection doesn't mean that you will go and have a cancer. Most people won't. And the good news is that we have a great HPV vaccine that prevents, I would say, almost like 90% of all these infections, precancerous lesion, warts, and cancer. But for those who were not vaccinated before exposure, that can be the older or later generations, I always say that the genital warts are benign and treatable, and we can definitely catch a lot of these precancerous lesions before they become a cancer through the cervical screening and the cervix, the anal cancer screening and the anal canal. So we definitely have tools to find them before they turn into a cancer.
Thank you, Helen. This has been a wonderful discussion on anogenital warts and HPV, and I really appreciate your time. I learned a lot from you.
Thank you for having me, Meena.
This podcast is brought to you by the National STD Curriculum, the University of Washington STD Prevention Training Center, and is funded by the Centers for Disease Control and Prevention. Transcripts and references for this podcast series can be found on our website, the National STD Curriculum, at www.std.uw.edu. Thank you for listening and have a wonderful day.